Hello guys, welcome to my channel, and today our focus is malaria. Let's dive in. Malaria is a life-threatening parasitic disease caused by Plasmodium spp, transmitted by bites of infected female Anopheles mosquitoes. It is preventable and curable. Plasmodium falciparum and P. vivax pose the greatest threats. In 2024, an estimated 282 million cases and approximately 610,000 deaths occurred globally. The African region bears approximately 95% of global malaria cases and deaths, with children under 5 most affected. Causative agents. Main human malaria parasites: Plasmodium falciparum, most deadly. Plasmodium vivax, relapse possible. Plasmodium ovale, relapse possible. Plasmodium malariae, chronic. Plasmodium knowlesi, zoonotic, fast cycle. Modes of transmission: bite of infected female Anopheles mosquito. Blood transfusion, organ transplant. Vertical, mother to baby, life cycle and stages of infection. Life cycle: exogenous plus endogenous, exogenous in mosquito. Definitive host: mosquito ingests gametocytes from human blood. Sexual reproduction: right-pointing arrow oocyst formation in gut. Sporozoites develop and migrate to salivary glands. Infective sporozoites injected when mosquito feeds. Endogenous in human, intermediate host, stage 1. Pre-erythrocytic, liver. Sporozoites reach liver, which invade hepatocytes that form schizonts. Schizonts rupture, releasing thousands of merozoites. P. vivax and P. ovale may form hypnozoites, dormant, leading to relapse weeks to months later. Stage 2. Erythrocytic, blood stage. Merozoites invade RBCs that releases trophozoites, hence later form schizonts. RBC rupture leads to more merozoites and the cycle repeats. This stage causes clinical disease. Stage 3. Gametocyte formation. Some parasites differentiate into sexual forms, gametocytes, infecting mosquitoes. Incubation periods: time from bite to symptoms, P. falciparum, approximately 9 to 14 days. P. vivax, approximately 12 to 17 days. Can be months, years if hypnozoites, P. ovale, approximately 16 to 18 days. Can relapse later, P. malariae, approximately 18 to 40 days or longer. Pathophysiology: step by step, infected Anopheles injects sporozoites during blood meal. Sporozoites travel via bloodstream to the liver. In hepatocytes, parasites multiply. Pre-erythrocytic phase, schizonts rupture, right-pointing arrow release merozoites. Merozoites invade red blood cells, RBCs. Inside RBCs, trophozoites right-pointing arrow schizonts right-pointing arrow rupture right-pointing arrow more merozoites. RBC lysis right-pointing arrow hemoglobin release right-pointing arrow cytokine release right-pointing arrow fever, chills, anemia. P. falciparum infected RBCs adhere to capillaries, sequestration, causing severe disease, e.g., cerebral malaria. Clinical features: typical paroxysm. Classic fever cycle correlates with RBC rupture. Cold stage: chills, rigors. Hot stage: high fever, 39 degrees Celsius plus. Sweating stage: fever breaks right-pointing arrow profuse sweating right-pointing arrow fatigue. Symptoms: fever, chills, rigors, sweats. Headache, myalgia, nausea, vomiting. Malaise, fatigue. Anemia, jaundice. Splenomegaly. P. falciparum severe manifestations: cerebral malaria, renal failure, ARDS, shock, hypoglycemia. Diagnosis: definitive tests. Microscopy: thick and thin blood smears, gold standard. Rapid diagnostic tests, RDTs, detect parasite antigens. PCR, species confirmation. Differential diagnosis: fever plus or minus systemic symptoms overlaps with typhoid, dengue, chikungunya, pneumonia, sepsis, viral hepatitis, meningitis, encephalitis, especially if neurological signs. Treatment. Classification: uncomplicated malaria, fever plus parasitemia without danger signs. Severe, complicated malaria, organ dysfunction, severe anemia, shock, cerebral malaria. Uncomplicated malaria, First-line, artemisinin-based combination therapies, ACTs, are recommended for most cases. Artemether lumefantrine, artesunate amodiaquine, dihydroartemisinin piperequine, artesunate mefloquine. Special species considerations. P. vivax, ovale. Follow ACT with primaquine for liver hypnozoites, after G6PD testing, except in pregnancy. Severe malaria, intravenous, IV, artesunate is preferred. If artesunate unavailable, IV quinine or artemether. Supportive care, fluids, antipyretics, treat complications, hypoglycemia, anemia, seizures. Malaria in pregnancy, uncomplicated, acts safe in second, third trimesters. Many guidelines support acts even in first trimester with caution. P. vivax, ovale. Chloroquine for blood stage. Primaquine is contraindicated during pregnancy. Severe malaria. Treat aggressively with IV artesunate regardless of trimester. Breastfeeding. Standard antimalarials, including ACTs, are generally safe. Primaquine, tafenoquine require infant G6PD testing. Chemoprophylaxis. For travelers and high-risk groups. Chloroquine, mefloquine, atovaquone proguanil, doxycycline. In pregnancy, chloroquine and mefloquine. Prevention. Insecticide-treated bed nets. Indoor residual spraying. Environmental control of mosquito breeding. Seasonal chemoprevention for high-risk children and pregnant women in endemic zones. Prompt diagnosis and treatment to reduce transmission. Thanks for watching.